Good morning, everyone. I'm going to give people a few more seconds to join in before we start. Good morning, Virginia. Howdy. Okay, so first, before we start onto our new concept, I want to check and see if there are any questions after going already home after doing the content yesterday. Good morning, Anna.
Professor Bish, I had a question.
Yeah, go ahead.
Fallon, hi, sorry. I was doing the dynamic study modules yesterday, and we had discussed that after the 1 hour glucose test, it goes to 180 and then down to 155, correct?
The range from the book. Did you see where I found that information? Let me grab it for you guys.
So the book, I got the answer wrong because it said after 1 hour glucose should be less than 140.
It specify which glucose test that it was, the 1 hour, 2 hour.
It was the 1 hour. And then the plan of care was to recommend to do a 3 hour because it was too high, and saying it because her blood sugar in the scenario was 155, so I thought it was in the normal range, and then it said no, it needs to be below 140.
I'm going to try to find where I found that. I think it was in chapter 12. And then gestational diabetes. Where was it? In type 2. Oh, let me pull it up. It might be better in the back of the book to find where it was. Good morning, Christian. I think it was a reaction instead of the metabolism itself. So sexuality. When we give you a break, I will look that up, okay, for you.
Okay, thank you.
I'll find a specific page because I had it. I remember seeing it on the right hand corner, one of the pages there. So let me write that down.
I just wanted to make sure I had the right values correct. So
yeah, no, sometimes there's a discrepancy, and we bring it to the test provider just to make sure that it's not keyed incorrectly. So in the dynamic case study, so it says 1 step, and it's 153.
This one's saying it should be less than 140.
But the person's blood sugar was 153 and needs second, right?
Correct.
The one, I don't have the test. Well, you know what? I think I have the PowerPoint up. I think I just took all that. Let me see.
Professor, I see on page 2232 on the bottom.
Did I write that on my page?
No, I just looked in the book. I'm going through the book right now myself.
2232?
2232 on the very bottom first column. There's the fasting 1, 2, and 3 hour, and then on the top of the.
That's where I think 2232. 2232. reproduction, sexuality, reproduction. Why would I not think of that one? 22, 32. Yeah, part of, there we go. Yeah, so that's where I got the, so if they had to do 1 hour is 180, 2 hours 155, 3 hours is 140. And the one-step approach should not exceed 1 hour 180, 2 hours 153. So there's a discrepancy between their pages and the test, right?
Correct.
Professor, in the
That dynamic-
paragraph above, it says 50 grams 1 hour oral glucose to be given any time of day with no requirement for fasting. 1 hour later, plasma glucose is measured. If plasma glucose levels are elevated, equal to or greater than 140, a 100-gram 3-hour glucose test is done. And that's the second step, is the table you're looking at. The first step of the two-step is 140.
Yeah, that's the first step of the two-step. But what she's saying is the one-step test,
That's
right?
what-
Is that your question?
Right, it was a one-step test, and then also the PowerPoint doesn't say that. I just want to make sure.
But in the one-step test, it's not 140. You fast overnight and it's 92, and then at 1 hour, it's 180.
Correct, but in
Yeah.
the scenario that I did, it was a one step, and it said 1 hour should be less than 140, which that's where the discrepancy is.
Did that scenario come from?
She did a dynamic case study. She did a practice test. Right. Well, I'll correct the PowerPoint. But what we want to know is if in 1 hour, if it's high, you know, roughly, if you're seeing that it's in the 180s, 190s, around there, you're going to be concerned, right? Because we would expect that in an hour they start to process it and the sugar should be coming down. So the gist that I want you guys to get from it is that you turn around and know that if a person is having elevated glucose levels, you know, with a one step at 1 hour, they are going to recheck and do the two-step approach, right? If the second two-step is positive, then the person is going to most likely be diagnosed with the gestational diabetes. Does that make sense?
Yes, thank you.
Yeah.
Okay. The other thing that I want, somebody asked a great question yesterday, and I want to make sure that it's clear that it's deemed gestational diabetes because it happens while you're pregnant, right? If and the causes being that it's the stress and the change in the hormones and all the things that occur during pregnancy. What do you think is going to happen after the mom delivers?
The body will begin to regulate itself, the hormonal changes.
Right. And what happens with the gestational diabetes?
It'll go away.
Correct. So you're going to see that the diabetes, the gestational diabetes should resolve, right? The mom and the baby initially postpartum are going to need some follow-up and some closer monitoring, because we would expect that we would have some troubles with what? Their regulation of their
Glucose?
blood sugar. So we're gonna watch their blood sugars close. We're gonna look for signs and symptoms of hyper and hypoglycemia initially postpart after the baby is born, and we're going to be treating them as as we need to. The baby is going to may have some trouble with hypoglycemia, so we're going to be making sure that they eat frequently. We might be giving them some IV dextrose, right? And the mom may be having high blood sugars or low blood sugars, but we are going to be looking at what the levels are and treating them accordingly. So that's the tricky part. We're not always going to say that the baby is just going to only be hypoglycemic or hyperglycemic. We're going to assess each and individual situation. We need to know what we're going to do, which interventions would be warranted if the baby is low or if the baby is high. And the same thing with the mom, right? So if the mom has high blood sugars after delivery, what are we going to do? We're going to be giving them more insulin. If the mom is having low blood sugars after the delivery, we are going to, maybe give a little bit of IV glucose. We are going to give them more, maybe some food if they can't eat. That's where you'll see a lot of the IV fluids containing a little bit of sugar. If the mom's blood sugars are high, that's where we're going to do that rule of 15. We're going to check their blood sugar. We're going to give them a snack and then recheck again. So the nursing process, and you think about that wheel is circular. It's always going to be ongoing. We're always going to assess. We're going to do something about it, or come up with a plan, do something about it, and then evaluate our treatment. What we do may or may not work. Okay. So it will resolve. Generally, the mom and the baby will be watched, at regular intervals. Typically, about 6 to 12 weeks, the mom will have a follow-up for that to make sure everything is back to normal. And at that point, we will see, okay, the sugars have gone back. It's completely resolved, and there's no other intervention that's needed, except maybe going to be followed up every 1 to 3 years to see if they are developing the type 2 diabetes, right? At 6 to 12 weeks, or if the mom's having trouble sooner, we are going to turn around and do some interventions. Maybe the mom will need to stay on insulin. All right. But all of that stuff is going to be followed up, and how frequently they're followed up will be dependent upon how the mom is doing after the delivery. Okay. Any questions about that? Nope. Okay. All right. We're going to begin talking about the concept of the book calls it trauma. We had it listed as violence. It's pretty much the same thing. Things that we want to go back and remember. We talked about, the initial introduction to the concept of trauma last semester. And now we're going to hone in on just abuse, and that's going to be exemplar 32.A. Okay. All right. So these expected outcomes, you could read it. Things that are going to be important for you to know is that abuse is not, it doesn't affect one race, one socioeconomical background, or anybody. It can happen to anybody. All right. So the misconceptions is that it only happens to weak people. It can happen to those who are very strong-willed. Okay. The one thing that is something that they do see is that it tends to be secular as well. If somebody has been abused previously when they were younger, they may have a stronger predisposition to repeat the patterns of behavior in which they have learned. Okay. We find that people who tend to abuse other people are doing it to gain control over the other person. we think about, and we talked about it, I believe, before in the past, that abuse can be physical, emotional, sexual, or categorized as neglect. Okay. Sometimes the abuse does tend to progress in severity. So if you see that it tends to start off with just emotional abuse, it tends to escalate. And then it arises from emotional abuse, just where they're being yelled at. You might see that if things aren't taken into control, or the person who is doing the abuse doesn't seek help, it may spiral into, or actually develop into, physical or sexual abuse. Okay. Why does it happen? Sometimes it may be neurobiological, path. It may be connected to psychology or underlying mental health disorders, or it may be something that is learned. Okay. What are some of the factors? Age, gender, physiological development. So we think about our population from our last year's discussion. What population did we think, or which people were a greater, had a greater chance of being abused?
Elders.
The young and elder. Okay. Children and old. What I'm also thinking of another protected class.
Handicapped, disabled.
Yeah, disability. There you go. All right. I think we will see that it tends to increase based on socioeconomical factors. If there's a substance abuse issue in the with a person, or if there are firearms in the home. The most important thing that we are going to be doing as nurses is identifying patients who are coming into the doctor's office that are showing signs that they may be being abused at home. We need to pick up on some of these signs and symptoms that we will see. Sometimes a person will be very clear and come out and say that they are being yelled at home, they are being hit, or they aren't comfortable at being home for various reasons, and sometimes they don't feel that it's safe to turn around and share or disclose that type of information. Okay, so one of the things I want to ask you guys is, what are some signs that might be very clear that a person is being physically, emotionally, or sexually abused? What would give you that? Bruises? Yeah. Here, withdrawn. Okay, distancing, flinching, jumping. Okay. Those are great. So when we see that, we want to turn around and try to intervene. When we do our admission process into the hospital, we are required to ask the patient if they are safe at home, if they feel like hurting themselves or others, as part of the questionnaire. So we always want to make sure we do that. You will see it when you complete an admission. And if you guys have an opportunity to watch a nurse complete an admission process in the hospital, that will be a great learning activity. And you will see that the question is asked. And it's often a question that is very uncomfortable for nurses to ask. Okay. And remember, we talked about mandating reporting. Nurses are required to report any type of child abuse, elder abuse, according to the proper protocol. Okay. Other things that we are going to do is try to prevent this abuse from going any further. We always want to make sure that we talk to our patients about a safe plan. What can they do? Can we refer them to shelters or other community resources that may be able to help them? And I put a picture of Safe Haven, and that's one of the common places that you guys will see that are available. There's one, I believe, right across, where you guys park and at the Waterbury Hospital in the back there. I believe there's a shelter there for women. And it's important that we talk to the patient, male, female, whoever it might be that's being abused, about developing or coming up with a safety plan. We want to turn around and say, pack things that are important for them, things that they will need. Right? So what do you think that a person should pack in and have a bag ready if the situation becomes to be too much? Money, ID, keys, clothing. Yep, emergency things that are going to be important. I would think about your ID, birth certificates if there's children. There you go. Enough clothes, not too much, and any important medications, right? The hard part is money sometimes if they could pocket it away. But we talked about control being an issue. So the person or the abuser often will even control the money. So they have to find a way to pocket or hide some money so they have that available to them. Because sometimes if the person doesn't have money, then they don't have the opportunity to leave. So do we confront somebody in the hospital that you think that are abusing, like they are? I tend not to confront that person, and it's very dangerous. Yeah, we don't want to talk to the person in front of the person who we suspect that's abusing them. Oftentimes we will turn around and try to say, oh, they need to go to a test. We need to turn around and try to take them out and get them into a safe spot where we can talk to them. They're not going to talk up in front of the person that is hurting them. So it's important to do that. And we want to try to be on the down low to try to get them out. The person still has the right to refuse to press charges, or they have the right to go back home with that person. So it can be a very challenging situation. Yeah. And that is a great point, Alyssa. You can make the situation worse for that person, because if they turn around and they speak up or they say something, then they know the moment that they're going to go home that they may have some retaliation on them. I'm not sure if that's the correct word for that. Okay. So abuse can happen throughout the lifespan. It's important to be able to identify signs in each person as they grow up. So when you think about the infant abuse, what kinds of things might you see that would allow you to, or cause you to suspect that an infant is being abused? Failure to thrive, yeah. We're going to talk about failure to thrive when we talk about nutrition, broken bones, bruising, lack of attachment to parents, spiral fractures. That's a great one, James. Head trauma, yeah. There you go. Cigarette burns, marks. Yeah, great. Diaper rash can be a sign of neglect, poor eye contact, resistance to touch, frequent and recurrent hospitalizations. That's excellent. And a lot of that can also be the same signs that you will see in a young child or your adolescence, right? Bullying, you're going to see some withdrawing and some difficulty. Some of the times, other symptoms, we will see that kids don't want to be around the people that are bullying them, especially if it's occurring at school. They may used to like going to school every day, but now they're saying they don't want to go. That's a great indication great indication that you want to do some further assessment. Okay. Intimate partner violence, IPV, means that the person who is the abuser of the person is somebody who they have an intimate connection with. It doesn't necessarily mean that they actually have to be married, because the term used to be domestic violence, but they changed it to consider that people might be just living together, they may be dating, so it's a broader cohort of people that they are talking about. Okay. Signs of sexual abuse, that's going to be a little bit different. What would you tend to see in somebody who you would suspect has sexual abuse or being sexually abused? Yep, maybe. And Stephanie, that's a great one. STDs is a great example. You also want to turn around and see if the person, thinking about the age of the person, too. Would you, if it's in a small child, you definitely wouldn't expect them to have any tearing of the hymen, or you would want to be assessing the rectal area, correct? Also, especially in teenage girls, we want to and see if they are sexually active. If they're telling you no, we want to do some further evaluation, especially if they, we want to turn around and check for pregnancy tests. Yep, there you go, Anna. And STDs. And that's usually some of the first signs that we pick up on, unfortunately. Okay, and then the elder are going to be, they can, it can be hard to take care of an elder person, can be tiring, just like it is with, an infant that might be sick or crying or anything like that. And, you want to think about physical abuse and abusing them or taking away some of their financial resources and controlling them or misusing their funds. Okay. All right. So what are the signs and symptoms? I think we kind of talked about that. We want to make sure that we are assessing the person all the time for these signs and symptoms, and making sure we know the difference between physical, sexual, or emotional abuse. A lot of times we will see people will downplay the fact that they are being abused or controlled, because they will turn around and say, but I'm not being hit. I'm not being hurt. They never touched me. Okay. So it's important to do some education that still can be a form of abuse. All right. I think we talked about that, the infant. That. All right. We can skip some of that. All right. Good. All right. some things that's going to be important is make sure we are mindful of some cultural considerations before we just jump to the conclusion that abuse might be happening. But other countries and other cultures, what you skip, we don't need to know. No, we already turned around and went over all of those. We kind of talked about what were some of the signs and symptoms on the other people. And this, I believe you guys also have a narrated PowerPoint, correct? So we talked about, right? We talked about bullying, right? So we can, if you want me to go back into them, because you kind of put this in the chat, right? When you guys, yeah, no, you do need to know it, but you guys kind of came up with the answers pretty good. So I thought for sure you guys had read or listened to it, and I didn't need to go slide by slide over that. The one thing that I would say is very important, and now as part of your once you guys become a registered nurse, you guys are going to be required to maintain continuing education hours. So it means you guys are going to be required to attend workshops each year to prove that you guys are staying current with, you know, your evidence or nursing practice. And one of the things that the state of Connecticut has added as a requirement is that nurses attend conferences on post-traumatic stress disorder and suicidal ideation. And you have to attend 2 hours of continuing education based on these two topics. And I believe it's 2 hours every 6 years. And you need to have proof or a certificate stating that you have attended these in-services. And the importance of it is to be able to pick up the warning signs of somebody who has experienced post-traumatic stress. And somebody who is abused might be demonstrating some of these signs and symptoms, but we also want to know that we don't want to minimize the effects that, you know, emotional, physical, sexual abuse and bullying can have. Especially now we are seeing that children are being bullied in the school much at younger ages, right? We're seeing low self-esteem, a lot of anxiety, depression, and we've talked about anxiety and depression in the past having a correlation to suicidal ideation. And I think we did talk last semester about this type of abuse can cause anxiety and lead to depression. And the big thing is we don't want to minimize, you know, the effects that this has on somebody. So we will see that a person might start to have suicidal ideation or actually attempt suicide, right? And I have attended 2 workshops this semester already, and they were very enlightening. And it talks about over symptoms, over presentation. You know, a person that comes right out and says, hey, I think I'm going to, you know, I don't want to live anymore. But we also want to be able to pick up on subtle comments in which a person might make to us. Okay. So I did just brush over them to save time because I figured you guys could read that or have already heard that. All right. And here again, just as you guys talked about with sexual abuse, these are the manifestations, you know, injury to the genitals, anus, bladder, kidney infections, STDs, and unintentional pregnancy. Okay. Neglect, diaper rash, somebody mentioned that, poor hygiene, eye contact, failure to thrive. So I think we did turn around and and cover that, I think, with our chat box there, and you can read, there. What is important to know is that you guys are going to be working with many different professionals, social workers, physicians. You may wound up getting involved with working with the authorities, right? Our job is to make sure that we create a safe environment while the patient is in the hospital. And we want to make sure that we develop a therapeutic relationship or an environment in which our patients feel that they can trust us, okay? The other thing we want to do is to avoid making false promises. So for example, we have a child that comes in, and if the child doesn't want to speak up because they don't want their parent or caregiver to get into trouble, we don't want to say to them they're not going to get in trouble, because what is that going to do with our relationship with that child?
Break the trust.
Right. They're not going to trust him. You told me that they're not going to get in trouble, so we don't ever want to do that. It's like, once you make children are funny like that, right? Once you say, I promise you we'll get this there, you want to make sure that we follow through, because they need to know that they can trust what we're saying. If we can't ensure that, we want to be very clear about that. All right. We also want to be explaining the different types of tests that the person will be going through. The way in which we explain the tests is going to be based on the age of the patient and their cognitive abilities, right? We are going to talk about medical or non-medical treatments that might be used. Okay. And then, as I always do, I put the nursing process in. What are we going to do? Our first step is going to be assessment, right? What do we need to assess? We need to assess the severity of the person's injuries, right? If a person comes in that's been physically or sexually abused, what do you think the priority is going to be for that person? Right. We're going to treat the physical injuries first. Correct. We're going to do a medical history. We're going to assess the patient's mental, emotional state, and we're going to try to help them the best that we can. We're going to diagnose them. These are some of the things that we will see as possible diagnoses. We're going to come up with a plan for them. We want to make sure that this patient has a way to remain safe and free from injury, right? From any further injury. We want to make sure that they're not hurting anymore, that their pain is manageable. We want to then, once they are stable, we want to try to resolve the situation. How can we help them? What kind of plan can we put in place, right? It's critical. I understand you may be worried. Oh. I understand you may be worried about what is going to happen to your parents, but you might be concerned. But my main concern is for you to be safe. I want you to be safe. Correct. And that's great. You're not promising them that nothing is going to happen. Oh, that was for Nicole. I didn't see her. Oh, what would the proper response be? There you go. I'm sorry. I was trying to connect. It's all right. And as you see, definitely we have to report any type of suicidal ideation, and making sure that our patient is safe. If they are thinking about harming themselves or say anything, we have to take that serious. Any subtle or unsubtle comments that are there, we need to intervene. Okay. Then we have to be able to help them to develop healthy coping mechanisms, they have to learn how to deal with the feelings that they have. And that's a more long-term type of outcome, all right? We're going to implement our plan, promote safety, establish a therapeutic relationship. We want to make sure we have open communication. And the biggest thing that we need to do for our patients is promote empowerment, right? If they have been feeling that they have been controlled by their abuser for a long period of time, we need to make them feel like they are strong enough, that they are worthy, because they've heard for a long period of time that they're no good or they can't do things, right? Because that person has used that language to control them, to keep them where they need them to be. All right, then we need to evaluate. Did we treat all their physical injuries? A lot of times, you know, with sexual abuse, they may not come in, you know, if it's a female, and have a negative pregnancy test, we may want to evaluate them in a couple of days, to see if they do, you know, wind up testing positive. Same thing with STDs. They may not have them right now, but we might want to do some follow-up checks, to see if they do develop them. We always want to then talk to them. What is the safety plan that they have in place? Are they going to be able to implement that? Right? We want to give them resources. So if they do decide to go back home, we want to make sure that they have assistance when they need it. Who do they call? Who are they going to get help from? Right? The biggest thing that we also want to do is make sure that they have the opportunity to get some social, you know, some support. And if you think about a person who is being abused, they might not have access to a car. They might not have the freedom to just go to therapy, to meet with a person to talk about that, because every move that they make might be being controlled. Okay? So that's abuse. The next exemplar is going to be about rape and trauma. All right. So with rape, it is going to be an act of penetration, no matter how slight it may be, of the vagina or the anus or any other body part with an object. It doesn't necessarily have to be a sex organ that they're using. They can use different devices in order to penetrate a person. Okay. In the next line, it should say healthcare providers want to use the term survivor rape versus victim. Why do you think we want to do that?
It empowers them.
Correct. Right. That helps them. The term survivor means that they have overcome, they're resilient, versus the word victim. And I try to make sure that I change that language, or I try not to use that language, because that's kind of the way that they've already been referred to for a long period of time. Victim makes it sound like that they are weak, that they've been preyed on, or something that, and I think, as Nawid has said, make them feel bad about themselves. It also helps their self-esteem, right? Okay. So rape can occur in a lot of different situations. We want to know that just because a person might have gone out on a date with a person, or they know the person that has raped them, it doesn't mean that it's still not rape, right? As long as there's no consent and consent doesn't always have to be the verbal no that they are stating. So a lot of times people will say, well, I didn't say no. Well, did you say yes, or did you, consent to it initially? And a person can take back consent at any moment in time. Okay. All right. A lot of the factors that will lead a person to rape or be raped are very similar to that of abuse. Sociological or social cultural factors or interpersonal factors. Okay. And on this slide, that's kind of where I was leading to, is can a person be raped by their spouse, his or her spouse? Yes, they most certainly can. You can still say no if you don't want to engage in intercourse at that time. You have the right to say no. Acquaintance rape is kind of the term that's taken over for date rape, which means that you did know the person that has committed the act of rape. We see a lot of this occurring in college campuses. And we want to make sure that people are aware of that. Just because campuses, such as ours, we are not living in dorms where you might expect it to happen. A lot of times, it still can happen. And in the community college or college students who are commuting. All right. A lot of times you will see that people might use substance to hinder the person's inability to say no, or change their ability to be able to consent to engaging in the act. All right. Rohypnol, GHB, and ketamine. These are known as date rape drugs. They make the person unable to almost, they can have a loss of control of their body, and they can't consent, right? A lot of times are blackout, right? A lot of times you won't smell them. Things that we thought about, you had to think about when you ever go out to not only in a regular, a party situation, but if you go out to a club or a bar or anywhere, even, just a date with somebody, you never know nowadays. They can slip something into your drink when you're not looking, because it's colorless, it's odorless, and the drink can be the person will drink it without even knowing that they had any thing added to their drink. Okay. They have nail polish now that changes color if it comes in contact. Oh, is that a safety thing, Samantha? You want to share that? You can. You just have to. Do you have to dip your finger in the drink? That's very cool. It kind of gross, but it helps. Yes. Well, you never know. And a lot of times people will not get open glasses, like the mixed drinks because of that, but you could still mix it into, to a beer bottle or anything. But if you put a drink down and you haven't had it in your hands the entire time, I would not be drinking it. And buy your own drinks, yes. Okay, survivors. We want to try to increase the outcomes, make sure that the patient has outcomes. In terms of survivor, means that somebody who has, like I said, endured rape. We want to make sure that they are able to deal with the situation that has occurred and have the ability to cope with this, with what has happened. All right, same thing. We want to make sure that they are safe initially, that all of their injuries are treated, and then we want to work on the long-term goals. All right, prevention, and I think we talked about this. So what are some strategies in addition to what I've listed here? So we want to make sure that we know how to keep us safe. What are some of the things that we could do on campus, off campus, to make sure that go in pairs? Yeah. Pepper spray. Call security, right? Always know the emergency number. You know that 8114 on campus will get you to the security. Dial 911 if we can, or text if you cannot. A secret code to notify your friend if you're in trouble. Awesome. So that's something that you can text them and they will know. And always making sure you let them know where you're going, who you're going with, right? Keep your GPS tracker on your phone. Yeah, texting is a great idea. Have someone at least know where you are. Good. Great. All right. And let them know when you're going to be back around. Right. Good. Okay. And you always have to have a plan. Somebody needs to know where you're going. If you ever go on a date, especially from a dating website, send them a text picture of who they think you're going out with, or at least they're possible, share that phone number with somebody else that they have. All right. So we're going to see that a person who may have been raped will have some physical injuries, swelling, lacerations around the vagina or the rectum, injuries in the throat. They may have bruising, broken bones, and it may even get very violent if they're being held at gunpoint or with a knife, somebody that's going to be hurting them. So we are got to be very making sure that their physical injuries are treated first. Okay. Sometimes we will see defensive wounds because the person is fighting back, right? And even if we don't see any, overt bleeding, the person can still have some internal bleeding that will arise. That we need to. I did some research. The nail polish thing doesn't seem to exist yet, but I did find undercovering. Okay. Thank you for sharing that, Ryan. What happens immediately? A lot of times you will see that the person is in shock or disbelief. Like, how did this happen to me? I didn't, I thought I knew the person. It can be somebody they knew, somebody they don't know. And then they're kind of going through different feelings, anger, guilt, embarrassment, sense of feeling helpless or loss of control, develop your anxiety or the depression if it's long term. They'd be very hesitant to trust others. All right. They tend to want to wash away the incident or their attacker. And what do we want to make sure that we teach other people about that? Like, what do you think is important about showering? Evident. Yeah. Good. Don't shower. We need to keep the DNA. There you go. And they should do the rape kit first. Exactly. All right. Okay. with this one, what is the long-term response? And this is where you're going to see your PTSD, and you guys are going to talk about PTSD in greater details in the future. Anger, flashbacks, lack of interest in things that previously found in enjoyment. Sounds like depression, right? Eating disturbance, insomnia, sexual dysfunction, depression, suicidal thought or ideation. They may become withdrawn or develop unhealthy coping mechanisms. And what do we, drug abuse is common. There you go. I was just going to ask, what type of unhealthy coping mechanisms might we see? Alcohol, drugs, yep. Okay. Eating might be another one.
They might even
Smoking.
engage in unhealthy sexual activity still.
Correct. Yes, the promiscuity, you know what I'm trying to say, being promiscuous might develop too. And also thinking back, a lot of times the possibility of pregnancy is there. They tend to give the morning after pill or something to prevent pregnancy from happening. A lot of times people don't report being raped immediately. They try to hide it, or they're not, they don't want to say anything. They're embarrassed or they're afraid. So they might not realize that they are pregnant until later on. So then thinking about some ethical or, religious concerns about that, some people might not believe in terminating a pregnancy, and this can lead to a whole lot of other long-term I would say, I don't want to say consequences, a lot of things that they will have to deal with, for a longer period of time. Okay. A lot of times people, might think that only women are the ones who are being raped. That is not true, right? And some cultures feel that a woman is a possession and that they have a right to do whatever they want to that person. Okay. All right. So people who have been raped may develop a rape trauma syndrome, right? During the acute phase, acute meaning that it's the immediate time after that it has occurred. They might start to develop some feelings, somatic reaction, periods of anxiety, depression, guilt, those things that we talked about, the different clinical manifestations that they will demonstrate. Later on, they start to develop anger at the person who has raped them. They might be angry towards society or the judicial system. They need to make sure that they are seeking out support from family and other professionals. Okay. If they do not seek immediate, seek treatment, and even if they do seek treatment, they can develop post-traumatic stress disorder. Okay. All right. So during the immediate situation, when the person comes in, if there's injuries, we want to start working with other professionals immediately, treating the injuries, doing diagnostic tests, checking and collecting specimens for evidence. We also need to think about the STDs, potential pregnancy. HIV testing is going to be done at baseline, and then there's going to be a follow-up 3 months, 6 months, and 12 months. Okay. The emergency contraception, STD treatments, and the non-pharmacological will be referrals to support groups or counseling. All right. Lifespan considerations, what are you going to, do for the patient is going to be based on how old or how young You want to stop and think that for your young children or women who are postmenopausals or postmenopausal women or males, that emergency contraception is not going to be warranted, right? Younger people or older patients, they might need more help developing a safety plan after, right? Because if you think about your young children, they're going home, or your older patients are going home with that caregiver. That might be the person that has harmed them. And it not necessarily has to be their caregiver. It could, a parent could be bringing them in because an aunt, uncle, babysitter, or anybody else might have been the person that has done the assault. Okay.
And also it can happen where if something happens and the perpetrator is arrested or removed, then all of a sudden they lost a caregiver. So.
Correct. That's a great point, Ryan. A great point. And what do we do? Who do we contact, right? When you talk about, who do you think we would be referring them to? Social services. Yes. Excellent. DCF, especially if it's a younger child. I think I put some resources at the end of the slide. I'm not sure, like emergency domestic shelter. There you go. There's Safe Haven. 911 has really great resources for people. They have hotlines that are available that can be called, and it's a relatively easy number to remember. Okay. Process assessment, making sure that the person is safe. And most important, we want to treat the severe injuries first. If somebody is bleeding, or not sure if they're bleeding, but they may be complaining of severe abdominal pain, we want to check to make sure that there's no internal injuries, right? We want to make sure that the patient is, we're able to, kind of help them calm down a little bit, or we might see that they're not talking because they're in shock. We are going to make sure that they're comfortable, explain to the patient that they have a choice for the examination. A lot of times people who have been raped don't want to be examined or seen. It's very uncomfortable for them. Right? Want to make sure we collect the evidence. We might not be the ones who are actually collecting the evidence. A lot of hospitals have, I think the term is called a SANE nurse, who is responsible for collecting the evidence, and it has to be done in a very specific way, because this is going to be used perhaps I'm trying to think of the word, is if they do go to court or is used for prosecution, trial, there you go, court of law. It's been harvested or collected in a matter in which it cannot be disputed, tampered, or contaminated. All right. We are going to assess the patient's emotional needs. We might want to ask, do they want a parent, a friend, or an advocate present, somebody to be there? Sometimes, depending on the age too, a minor might not want a parent to be present. Sometimes they might not want a parent to know. Okay. The person has the right to involve the police, and it's their choice to file a statement or not. So we want to make sure that we offer them that information, right? Depending upon the person's age, right? Might not have the right. We are going to be contacting the authorities or somebody. We are going to be making sure that it's reported. Right. These are some possible diagnoses. A plan. So what's our plan? What are we going to do? We are going to make sure that the patient has the treatment that they need. We arrange follow-up care for them. We let them know where they should be seen or who can support their injuries. Making sure they have the safety plan upon release, right? Those are our short-term goals. Our long-term goals is making sure that the patient gains control for flashbacks, nightmares, works towards being able to deal with the feelings that they have, being able to reconnect with others, and then eventually in the long term finding meaning in life and no longer feeling as if they were the victim. Okay, this is the information about the sane nurse, and there is a link here that gives you some information about the role of a sane nurse. This is something that, if this interests you, it is another role that nurses do. Typically, you will see them in the emergency room working. They work to provide comfort for the patient. They facilitate an evidence collection, treating the injuries, and empowering the patient. Okay. Lastly, we want to make sure that we evaluate all of the things that we have done for the patient, making sure that they are empowered. They discuss fear, coping mechanisms, ask for help when they need to, right? One thing that I would say, here you go, there's some links here. For ending sexual violence, the survivors and survivors, sexual violence webinars are here. All right, so the one thing we're going to do, I'm going to give you guys a few minutes, about 5-minute break, right? And we have 2 activities that we're going to do. And we're going to, you should see in the in-class handouts that we have some activities, right? Let me pull them up here. Stop sharing this. What I have. All right. So if you don't have it now, we are going. You guys, I'm going to break you guys up into breakout sessions, right? And you guys are going to see that there's going to be 4 different groups. If you are in group 1, let me let you guys have a 5-minute break. Come back about quarter of, is that 5? That'll give you 7 minutes if you guys want to stretch, and come back at quarter of, and then we can go over the discussion here, activities. It's important to think about for this patient is, what about the patient?
She's pregnant.
She's pregnant, right? Yeah. All right. So she's not only at risk, but who else?
The fetus.
Yeah, the baby. There you go. All right. So question number 1. I want you to think about questions the nurse could use in continuing to assess her and to document the discussion with Lucy. So what are some things we might want to ask? How are we going to proceed with this?
Maybe
Ask her if she does have a plan for getting out.
Right.
Yep. Ryan has, do you have any support? Who can you go to? How long has the abuse been going on? Is there somebody that else can pick her up when to start support? Yeah. Do you have somewhere else to stay?
Does she want to press charges?
Exactly. Do we want to press charges, right? the other thing is that you want to turn around and see is she fell and she hit her head at home. We don't want to discount the physical, here I'm telling you the answer. We don't only want the abuse, but we want to turn around and look. We physical injuries now, right? This patient is having headaches. What are we worried about? She fell and she hit her head. She's having headaches. What might be going on? A concussion, right? A head injury, hematoma. We want to make sure that we are treating that first. So that's one way we can get her out of there. We need to send her to get these headaches evaluated for, right? Might need a CAT scan of the head. And at that time, we could be asking some of these questions. She's saying that she's clumsy and falls a lot. What do you think that part of it? What's that?
Like maybe check the fetus on a monitor, make sure there's no injury to the fetus.
Correct. We want to check the baby as well, right? And excuse.
Saying that
That's
she's
great.
clumsy and falls a lot is is incongruent with her head injury, because most people don't hit their head when they fall if they're not drunk.
Correct. Why, Anna?
Our natural response is to catch ourselves. So if something
And to
hurt, it would be like maybe a wrist or an arm or shoulder or something like that.
Right. That's exactly. So you're using your judgment to turn around and say, well, does this story even make sense? She's saying she's clumsy. But, I could, if anybody's ever been pregnant, when you're much further along, your center of gravity is off. Yes, you can fall. But again, your initial response, and I like that Anna came up with that, is you're going to protect your head. You're going to be using your wrists, and that's where you would typically see the injury. So making sure that the story that they tell you matches the injuries. Okay, excellent. And what other people do you think would be involved in Lucy's care in the emergency department? Case manager, trauma therapist, yeah.
Police, social worker.
Yeah, good.
And maybe what is that called? Like an obstetrician, maybe.
The OBGYN, yes. There you go. Excellent. The other thing I would want to make sure too, it was this pregnancy planned or not. The other thing it could be is she could have been, raped by this person. She might not necessarily wanted to become pregnant. It might not have been a plan. She might also been feeling that she's kind of trapped. The one way that people can try to control people is if they threaten to leave or to do something, it may be somebody else's baby too. There you go. Right. Yeah. You never know. I made the assumption there, Anna. Okay. I was just going to go with a thought. I just had a thought. I can't remember. Oh, about the cycle of abuse. Do you remember that? When we talked about it, the honeymoon phase, the different stages. Yeah. So a lot of times as part of the honeymoon phase, they turn around and say, oh, I love you. And they wine and dine them, or they treat them very nice, or we're going to be a family. They may be using that as a way to control the person. And sometimes if they have, children together, they kind of are in their life a lot longer. It's a little bit harder to separate ties too. So it can be a way to control the person.
Professor,
Okay.
Sure. So nurses are mandatory reporters for child abuse and elder abuse, but not for domestic violence. But in this case, there's a fetus involved. Do we have to wait until the baby is born before we report this as abuse?
The person still has, just because we're not mandated to report this, can we still help this person? We're not saying that we're not going to turn around and contact the authorities. We're going to turn around and give this person support, right? We can implement all of these. The DCF isn't going to get involved. What DCF is children and families, and I think they, there needs to be other people involved there. I'm not 100% sure. If they wouldn't, but I would turn around and say this is a person who we may be calling 211 for, getting her into a safe haven. So the next question is, where should she go? And it's a decision about where she should go.
Professor Bish, but we do have to document that, like this patient does not feel safe going home, because like when we do our assessments, we ask them, do you feel safe at home? Is anybody hurting you? So we do have to put that in the documentation, what she is stating.
Right. And that's where I'm going with it, is just because we don't have to mandate and do that, we are still obligated to turn around and help this person, right? We're still going to turn around and do it. She ultimately has the decision if she wants to go back home with that person. She has the right to refuse to file, charges. But can we contact authorities? We're going to contact our supervisor, and they're going to talk about the policies and the procedures. She could turn around and want to press charges on this person, and the police may come. And intervene and get involved. Does that make sense?
Yes.
All right. All right. And this is where the shelter might come in handy too. The other thing is if this person decides, and it can be frustrating, what we often see is that these patients, because they go through the cycle of abuse, they turn around and they say, oh, no, they love me, and I'm going to go home with them. They promise not to do it again. And then we're going to see them back again. Maybe for another injury. Maybe as we talk about the escalation getting worse, the person may come back with, far greater injuries, or there may be harm to the unborn child. I would think, because the baby is there, I'm not 100% sure, and something that I think I would ask our maternity instructors for their expertise in it, is just if she is pregnant, is she protected or not? I don't know the answer to that, but that's a great question, and I will see if I can get that answer and post it for you in the discussion board. Okay.
Thank you.
Yeah, I will try to find out. But the thing of it is that, this person might come back, and it's very, you can see a lot of times, and it's important not to get frustrated or start to say, oh, she's here again, or she didn't want to go home last time, or, nurses can turn around and do that with our patients who become what we term as frequent flyers, that come in multiple times and do that. But we want to make sure each and every time that this person comes in, we treat them with respect and offer them the support and the help that they need, because at some point they are going to be hopefully comfortable enough to leave the situation. We just can't make that determination that they need to leave or at that point in time. Does that make sense? Okay. All right. Okay, so we're going to do an activity. I'll give you about 15 minutes to turn around and do this, and then we'll come back and we'll share some information about it. Okay, we're going to break you up into 4 groups. The first thing is write down some personal beliefs about intimate partner violence. How comfortable would you be in interviewing a person who has been abused? What would you say? I think we kind of talked about that a little bit in the discussion. I think somebody put a nice statement, but I think that was more so for about the abused child. And then after reviewing the sample care plan, I want you to come up with a care plan that talks about things that we would include in the various type of scenarios here. For a woman who has been raped by her husband, a 22-year-old male, a 14-year-old male who was raped at a party by somebody on the athletic team. And then group 4 will be doing a 30-year-old professional who was raped by a superior. And it gives you different scenarios, like you think about what do we need to do for this individual person, okay? I don't know if you had enough time, but I just we have about 10 minutes left to class. So I just wanted to make sure people got to share their information with the group.
We
So
just
that's
didn't.
Mostly. Okay. So the first thing that I want to ask, does anybody want to share, not necessarily your own personal beliefs about that, but were there any thoughts or feelings about partner violence or rape?
Happens way too often.
I think, Arena, I'm not sure if you wrote them down, but I think we compiled a pretty extensive list of thoughts.
Hold on. So
High
we had it's usually the person you least expect. You may have a relationship with the attacker. If they do it once and get away with it, it may be done again. They may have extreme trust issues after the fact. And it may be the same sex, or it may be a female attacker or a male.
Excellent. And that's the thing that I want to make sure we bring to the front line here of our thought, is that we don't want to discount that, that it doesn't happen from male to male or female to female. Because traditionally everybody just assumed that it would be male to female, and the male would be the aggressor in the situation, and that's not necessarily true. Okay. Did you have a question or want to say something?
I just wanted to say we didn't actually do this one in our group, but I wrote down a few of my own.
Okay.
One is that it has lifelong effects. It's incredibly hard for some people to see a way out, not just to get out. It can happen to anyone, anywhere. I'm blessed that it hasn't happened to me. And it's hard not to be judgmental in the case of what they call a frequent flyer.
Thank you for sharing your own personal beliefs, Anna. That was great. Okay. Anybody else with that one, or want to move on to number 2? How comfortable? Yeah, you have a right to say no, and a lot of people don't believe that, especially cultural. That's a great thing to point out. And how comfortable would you be in interviewing a person who's been abused? Personally, myself, I find it to be a very tricky situation. Being a nurse, you wouldn't be comfortable at all, right? Yeah. So I don't think we do a lot of, training in that area to prepare our new nurses to be able to be comfortable and talk with the patients. So I think that's something why we want to make sure we open the dialogue and feel like, what would we say? Like, this is a perfect opportunity for a process recording, right? Hard not to be, yes. Hard not to get, attached or to cry. And a lot of times we do feel empathy towards our patients, and it is a very difficult situation. And I think the most important takeaways with what we're going to say is making sure that the person knows that they didn't ask for it, or it isn't their fault. Any common things that you might want to, would you share with the person?
What do you mean?
Like, a lot of times people feel like they it was their fault. Oh, I was walking alone. I should have never did this, or had I not gone to the party, or if I didn't wear this blouse. You know what I mean? Like, they feel guilt about that.
Yeah, I mean, I just basically said that obviously nobody's gonna feel 100% comfortable, but just showing compassion and letting them know that you're there to support them, and that developing that open communication, and having them know that this process is in their control, and they can say, what, I need a break, or stuff like that. Just let them know that they're strong for coming in and stuff.
Well, and I think another thing that I think I'd like to get across is that this doesn't have to continue, and that we have the power to find the resources in order to make this stop for you, and we can make things better in that regard. This could end today. I don't know if that's maybe that's just my privileged point of view.
Yeah.
So I just want to say, like, when you say it would be hard not to judge the person. Like, I would disagree. I would know, there are some really bad people in the world. There's some really dangerous people. Like, if you look at the guy in California who just shot his 3 kids, like, there are very difficult people to get away from. So it's not that, I wouldn't blame the woman if she, or the whoever it is, that if they can't get away from the person. You have to realize there's a certain amount of really bad people who can be very difficult to get away from.
That's an excellent point. You never know if an abuse survivor doesn't have, 3 children back at home that they have to account for as well. And so that's an excellent point.
I agree. That's something I was thinking too. It doesn't have, I think what you were trying to say is the abuse doesn't have to continue, or you don't have to tolerate it. Is that what you're trying to think about, Ryan?
Yeah, I think
Like,
that's
we
what
can
I was
help
trying
you.
to say. Not that they don't have to tolerate it, but that we're here to try and end this, and
Right.
we have the resources for you if you choose to end this, I guess. I think it would I think it would personally, I would just feel like overwhelming need to just make it stop for them.
Yeah, and I think that had a great thing about you can take back control. Then, Stephanie, you also had another thing that I wanted to bring up. Confidentiality, making sure they know that you're sworn to their privacy and confidentiality. I think that was excellent. Okay, we have a few more minutes left. Anything specific? We don't have time to go over the entire care plan for each and every patient here, but what do you think might be some key assessments or key things that you would want to include for a woman who is married, or in that relationship? That relationship is bound by marriage, right? It's going to be a little bit harder for them to get out. Or what were some key things that you want to share? Just 1 or 2 things would be important. Or
so the marriage part just reminds me of this movie with Jennifer Lopez that she was in, and her husband was abusive. She had to change her name, she got a wig, and she had to have her friends come in and help her escape with her child because he wouldn't let her leave. So sometimes you need, like, outside people to help you get away from situations if you can't do it on your own.
Two good movies that I've seen about this would be Safe Haven. It's based on a Nicholas Sparks movie. And the other one would be Maid. I think maybe that's the one you're talking about, the series where the woman has to try to find her way out to protect her and her daughter. I don't know if that's the one with Jennifer Lopez, but that was another good one. Okay, well, with the marriage, it brings a whole different thing because you have to turn around the legal ways of ending the marriage, protecting the person, stuff like that. What about the 22-year-old male? Doesn't really say who, but they've been kind of raped by another person. They may or may not know.
One thing we discussed in our group was whether or not a rape kit is done on men, and we kind of assumed that, yeah, of course, if there was a crime committed, a rape committed, that that evidence is probably present, and that a rape kit would probably be done on a man. But that's nothing I don't think any of us had ever heard of.
Yeah, the reason why I put that one there would be difference would be as we mentioned with a woman, as long as they're of childbearing age, they're going to do the pregnancy test, perhaps dealing with that other aspect of it. The male, we're still going to do in the same collection. You're if it's man to man, you may be doing the mouth, the anal region for swabbing for evidence. Just thinking about that way. That's where I was trying to make sure that you saw the difference being that if it's a small child who's not menstruating or a young boy, it would be something that the pregnancy is not something you have to think about, but you would still have to think about the STDs and the trauma and physical injuries. Does that make sense?
Yes.
Yeah. And like within the 14-year-old girl, this person may or may not have entered puberty already. So this is a person, those are the questions that I wanted to make sure you turned around and looked at and say, okay, is this a young person of childbearing age? Is it a male or is it a female? That's where you want to turn around and make sure that you look at that. And this one may happen at school. Then the school may be brought into that, or it may be something that you have to bring up to that situation, not strictly just, they were at a party, so maybe not necessarily, but may get the school involved if that's where they know each other, and if there's an after, the sports and stuff like that. And then the other one is impacted a 30-year-old who was raped by a superior at work. Now, how did that change the dynamics?
Again, it wasn't clear if it was a man or female, so it could have conceivably been either. We encourage that person to report it to HR, or if there's a hotline for abuse in their company, or also to the authorities if they were willing to do that.
I think with that one, there's a lot of stigma too, like, oh, she's just saying this, or he just to get above, or, get a, whatever outcome.
And we said, and the one thing that I find disheartening, especially with the older generations, I see with my parents all the time when they women come up with these allegations, maybe after a long period of time, the stereotype is, oh, if that really truly happened, they should have reported it a long time ago, or she consented, or stuff like that. And I think there's a lot of stereotypes or misconceptions that need to be brought up. But a lot of times the point of being a superior at work is they're holding a power over them. They're using that work relationship as a form of control. Okay.
We did also discuss the fear of retaliation for them reporting it, and then fear of them losing their job as well.
Excellent. Great. Okay, before you go, while you guys were in your little breakout groups, I read the section, just want to make sure that it's clear for people. And I can't remember who the heck brought up the question about the dynamic case study, but whoever did, you could send me a screenshot of the question. I will bring it to Pearson for their review. But in reading the page 232 again, it sounds like it could be done. What they're trying to say is that you could either have the step or the two-step approach. That's going to be what's going to be ordered by the provider. Okay. In the two-step approach, the first step is that's the one that's going to be non-fasting. The person's going to get 50 grams of the solution, and then in the 1 hour interval, they're going to check and see, and they're going to be hoping that the blood glucose is less than 140. Okay. If it's not, they probably would follow through with the second step, is what I'm guessing. That's where they're going to have the 100 grams after eating whatever they want for the 3 days, and then have the test. So the two steps in that two-step, I believe, are going to happen not at the same appointment. They're going to do step one the first day. They're going to see if an hour later that they're going to be below or above the 140, and then they're going to schedule to have the second part of the test done. And in the second steps, that's where you're going to see the lab values on the bottom for doing it at the 1 hour, 2 hour, and 3 hour intervals. But if they're doing the one-step approach, they're going to have 75 grams of the solution in the morning after they fasted, and then they are going to check them at fasting, and 1 and 2 hours after, and that's where you're going to see the different points of them with the elevated sugars. Okay, so if I can see the question in the wrong, in the answers and the wrong answers, that would help me to determine if there was a issue with the question, and then we can make sure that we bring that to their attention if it was. So was there a question?
Yeah, I
Go ahead,
actually
Sandy.
have a question. So how would this question be abbreviated? Because I find it really confusing, like the whole step 1 and step 2. And also, I was stuck on slide 15 for interventions, where it says the 1 hour postprandial level. I can't understand that for nothing in the world. Like, does
Do you know what
postprandial
do you know what postprandial means? After
I
eating.
looked it up and it said after eating. But what does that have to do with the insulin therapy? And like in the top, it says insulin therapy when dietary management does not achieve control. So 1 hour after they eat, if it's less than 130, if the values is 130 to 140, what happens then? Like, what does that have to do with the insulin therapy?
So when we have somebody we check their blood sugars, right? We expect their blood sugars to be lower, right?
Mm-hmm.
They should be fasting. So we can see that. When we look at somebody's postprandial blood sugar, we know it's going to be elevated based on the amount of foods that they eat, right? If they're at 1 hour later, their blood sugars are still elevated, we are going to probably be adjusting the amount of insulin that we give them, or maybe looking, does that make sense?
So that just, okay. So pretty much depending on what their value is, the point of this is depending on what the value is, we'll have to adjust the insulin.
Well, we would turn around, it's hard to say exactly what we're going to be doing, because if somebody ate an entire bag of candy for their meal, and that's when we're measuring it, the level is going to be much, much higher. So we need to look at what it is that they ate, how much they ate, because that's going to impact their blood sugars. Does that make sense? So we want to do a further assessment of what it is. You know, if they just ate a whole bunch of pasta, spaghetti sauce, we know that that's going to elevate their blood sugars a lot higher than somebody who ate a salad with some chicken, right? So we want to turn around and just make sure that they're able to start to reflect, you know, their sugars are starting to go down after they eat. I don't have the PowerPoint in front of me to know exactly which, what statement is or there, but the key of that is to know we typically do our blood sugars before a person eats, right? Because that's what we want to turn around and know. They not necessarily be fasting, but we're doing it before they consume a meal. When we take a blood sugar after, we know that what they've eaten is to impact their blood sugar, and we would expect that a postprandial blood sugar would be higher than a blood sugar that we would measure after. So a lot of people who track their blood sugars, when they document their blood sugar readings, they document, is it before meals? Was it after meals? How much before? And they keep a track of what it is that they eat. So that way they can turn around and decide what kind of interventions we need to do. As you know, that it's, you know, sickness and how they're feeling can also impact their blood sugar. So we look at the whole bigger picture.
Okay.
I have a question in regards to the exam. Last exam I felt like there was like very like small changes in wording that could kind of trip you up with, you know, getting the correct answer. So with this coming exam, when you're going to be doing like the, you know, let's say testing 1, testing 2, you're probably not going to be doing like, you know, 142. You know what I'm saying? Like it would probably be more distinct.
It would be very clear with, it
Okay.
should be very clear. I would hope it would be very clear with the other distractors for you to identify what is
Okay.
abnormal.
Okay. And then my second question, I'm sorry.
No, go ahead.
So then my second question was with this person that maybe you're speaking with that, you know, went through a traumatic experience, there could be an issue with them becoming attached to the person that initially took the assessment, no? So let's say if it was a rape survivor and now they feel safe and comfortable with this person because, you know, Ryan said, you know, hey, you know, there's a way out, we're gonna help you, we're gonna do all this, and she feels super safe with this person, right? And the shift is going off. Like, how are we gonna be addressing that, and how quickly will we be addressing that? You know, like how.
So, yeah, it's important for us as nurses to make sure we don't get attached or we don't develop these inappropriate relationships or these or block our boundaries with it, you know. Sometimes you may stay a little bit longer to, you know, okay, you're going to be transitioning over. I know you're comfortable. Let me sit with you for a few minutes, you know, until, or let me introduce you to the new nurse that's going to be taking care of you. We want to make sure that we don't cross lines or blur them, or, you know, a lot of times you see, like, especially if you watch like SVU, like the Law and Order, they you know, they're not sleeping at night. They're trying to find their rapist and stuff like that, or they develop a relationship with that person. And it's important to make sure that we keep very clear boundaries with that person. We want to be therapeutic with, you're welcome in, that person. And we want to maintain a professional relationship. We're not going to call them after our shift. We're not going to be following up. We need to make sure that we end that relationship with them and letting them know, hey, we're, you know, I hope everything is good, or with you. I'm leaving to go home for my shift has ended. Let me introduce you to so and so. He or she will be taking